operating a patient with posterior subcapsular cataract and posterior polar cataract.
You should be cautious when you operate posterior polar. It is risky.
The posterior polar cataract presents a special challenge to the phacosurgeon because of its predisposition to posterior capsular dehiscence during surgery.
Posterior capsular rupture associated with posterior polar cataracts extraction ranged from 7% to 36%. This high risk of PCR is secondary to presence of area of weakness outside of adherence of congenital malformed lens fibers.
On slit lamp examination, it is distinctive, often very sharply demarcated opacity, discoid in shape and adjacent, and merging with the posterior capsule.
Physician should counsel the patient regarding 1. Presence of preoperative amblyopia, especially in unilateral cases. 2. Possibility of dropped nucleus.
Don't overfill AC with viscoelastic, as this will increase the stress on weak posterior pole. Create capsular hexes not more than 5 mm to have adequate support in case of PCR and silcus IOL implantation.
Hydrodelineation should precede hydrodissection to keep always up a nucleus. This cushion for posterior capsule. Once the bag is empty from the nucleus, hydrodissection is safe because the bag is depressurized.
Never do divide and conquer. Chopping is advisable. It should be careful not to mechanically rotate the nucleus. Also preferably to inject a dispersive viscoelastic through the side port incision before retracting the probe to prevent the forward movement of the iris lens diaphragm.
In epinucleus removal, some surgeons perform viscodissection. The surgeon then removes this rim with a coaxial eye/a handpiece. Alternatively, one may perform manual dry aspiration with a simple cannula.
Avoid polishing the posterior capsule due to its fragility.